Good afternoon, everyone. Welcome. My name is Eleni Ancelas. I'm from the Community Health and Wellness Department at Suburban Hospital. Thank you very much for being here this afternoon. Today we have Dr. Joseph White, vascular surgeon at Johns Hopkins Suburban Hospital, today talking to us about peripheral artery disease. But before he begins his presentation, I just want to go over a few housekeeping items. The first is that we're recording today's presentation and we'll make it available in the next coming days. We'll send out the link, so not to worry if you miss something. Secondly, if you do have a question for Dr. White, please put it in the Q&A box in the bottom of the screen and we'll make sure your question is answered. And the final thing, very important, is our evaluation. Please take a moment. I will send it after the presentation, but please take a moment to fill out the evaluation. We'd love to hear your thoughts, your feedback, what you learned, and any topics for the future. So thank you again. And thank you, Dr. White, for being here today. Greatly appreciate your time, and we'll get started.
Great. Well, thank you so much. I really appreciate the opportunity to provide some hopefully patient education and or future patient education potentially, and really just provide some information specific to vascular surgery. My goal for this talk today was to discuss peripheral arterial disease potentially in two arterial systems, which is the lower extremity and the carotid system in the neck region. So again, I'm Dr. Joseph White, vascular surgeon here at Suburban. I've been at Suburban for approximately 2 years now. Really have enjoyed my time. There's a wonderful team here at Suburban, wonderful experts and specialists that really allow me and my partners to provide just exceptional care on a wide spectrum of vascular surgery problems and pathology. Before my time here at Suburban, I was active duty military. Was in the U.S. Army for about 15 years prior to leaving the military and coming over here to Suburban. So again, today's agenda will look at two primary vascular territories. We'll start with the lower extremity and discuss lower extremity peripheral arterial disease. And then, time permitting, I have several slides on carotid artery disease in the neck and the ramifications of carotid artery disease. So what is peripheral arterial disease, or PAD or PAD? Basically, the peripheral arterial disease describes a state where the blood flow to the lower extremities is compromised. That reduction in blood flow is a consequence of narrowing or blockage within the native arteries. And in the case of the lower extremity, those arteries provide blood flow and perfusion to the limb, the muscles, and all the tissues of that extremity. The arterial structures are the structures that leave the heart and then provide all of the arterialized, oxygen-rich, nutrient-rich blood flow to the target. It could be the liver, it could be the spleen. In the case of peripheral arterial disease, it's the limb itself. There we go. So what causes peripheral arterial disease? At the most basic, the answer is atherosclerosis. Atherosclerosis is plaque formation within the arteries that can take several forms. But when it comes down to the pathophysiology of this process, as one accumulates this atherosclerotic process over one's lifetime, these arteries can be adversely affected. There's plaque deposition, there's arterial calcification associated with that injures and narrows the artery and potentially blocks the artery completely. It's not flipping a light switch, though. Atherosclerosis develops over decades to the point where you can achieve a critical narrowing or critical occlusion, and then suffer the clinical ramifications of that occlusion or blockage. So over time, the initial pathologic event is the formation of foam cells that ultimately develop into a fatty streak. These fatty streaks develop into lesions and atheromatous debris deposition. Those atheromas become covered by a fibrinous plaque. And then ultimately, at some point in the lifespan of that atherosclerotic lesion, That lesion is complicated by either plaque rupture, plaque embolization, where debris or material breaks off from that plaque and goes further down the bloodstream, or ultimately occlusion, closure of the artery as a result of significant atherosclerotic deposition within that arterial structure. Things like genetics play a significant role in the aggressiveness of atherosclerotic disease deposition. But there are lifestyle factors, such as, diet, exercise. What type of diet do you consume? Do you smoke? Are your additional medical problems well controlled, like high blood pressure, high cholesterol, high triglycerides? All of those factors can play a very important role in the development, in the accelerated development of that atherosclerotic disease process over time. So what are the symptoms of peripheral arterial disease? I really like this image I found the other day where it nicely summarizes what I'm listening for when I ask a patient, well, how do your legs perform? How do your legs feel when you walk or exercise? And the gentleman in this photo is grabbing his calf muscle because he's experiencing severe debilitating cramping pain associated with exercise or activity. The term claudication comes from the Latin, I'm gonna probably butcher this, but I'll do my best. Claudicatio, which is to limp. And I think that very accurately describes the symptoms that I try to listen for when I meet with a patient in my office. What I like hearing from the patient is when they walk or exercise, they experience very reproducible exertional muscle pain, either impacting the calf muscle or the thigh muscle. This is really the first sign from a vascular surgery standpoint that the blood flow to the lower extremities is compromised. So again, we're listing for exertional muscle pain involving classically the calf or thigh. And it's critically important that it's during activity and not at rest. During activity, the muscles need more oxygen. They need more nutrients in order to maintain their metabolic level. When there's a blockage in the arterial blood flow or a critical narrowing, the body is not able to deliver the appropriate oxygenated blood to that target, and that patient's metabolism flips. They go from an aerobic metabolism to an anaerobic metabolism. They get a deposition of lactic acid, and that causes that severe cramping muscle pain that patients experience classically. So again, the things that I listen for when I chat with a patient is that pain exertional? Are you describing the right type of pain? Are you describing a cramping sensation in a muscle group? Is your pain alleviated by rest? That's another classic sign for intermittent claudication, which is the term we use for peripheral arterial disease symptoms. So you should, and then lastly, very reproducible. And what I mean by that is the distance you travel on a flat surface, on a flat ground, at the same rate, the same pace of walking, you should uncover your cramping symptoms at about the same distance. We refer to that as your claudication distance. Patients should have a very consistent claudication distance. They should describe the pain to me as that severe cramping pain that makes them stop walking. And then those patients rest, the pain goes away completely. The next thing I like to hear is they can walk that same distance again, and then they have the recurrence of those very reproducible symptoms. And to me, as a clinician, you always like to link the appropriate clinical history with exam and then treatment plans. And so from my standpoint, those are specifically the symptoms I'm looking at to elicit during a history taking session, when we talk about your symptoms, to ensure that they're appropriate and consistent with peripheral arterial disease, again, or claudication. So not peripheral arterial disease symptoms. These are important to kind of help me decipher, is something else going on? And so the flip side of the symptoms that we just listed is your muscle pain occasional? Does it only come on certain days? Does it only come at, certain distances, and other days that distance varies? Again, with claudication or peripheral arterial disease, those factors, that distance should be consistent. The pain should be consistent. the alleviation, your leg feels better with rest. All that should be very consistent. So intermittent or occasional symptoms makes me think something else is going on. Symptoms not at exertion also make me think something else is going on. I frequently see patients for muscle cramps at night. Exceedingly rarely is that a blood flow problem. Typically, nocturnal muscle cramps is more related to your hydration status, side effects of medication. How active are you? Are you stretching? What vitamins are you taking? Is there a vitamin deficiency? Is there electrolyte deficiency? Those issues are far more common to cause muscle cramps at night than peripheral arterial disease. Other symptoms like numbness or tingling in the lower extremity or feet. Classically, those are more associated with a neuropathy than a manifestation of early peripheral arterial disease. In certain instances, that can absolutely be part of the clinical picture, but more commonly, when I see patients with this complaint, it's more consistent with a nerve-mediated problem or a neuropathy. And then lastly, the subjective description of my feet are cold. Again, rarely the temperature that the person experiences with their foot is not a good indicator of overall perfusion or blood flow. Now, obviously, if you have warm feet and then suddenly you start having a lot of severe foot pain and your foot is cold, that's a different story. That describes kind of a different process. But that chronic statement of, well, I've got cold feet, I must have a circulation problem. Usually, those don't go hand in hand. So how do we evaluate for peripheral arterial disease? History is critically important. The history is the story that you tell me, is your description of symptoms, and then my interpretation of those symptoms to see if they're consistent or not consistent. After we discuss what's going on with you, we move to physical exam. A pulse exam in vascular surgery tells me a tremendous amount of information. For most vascular surgeons, we would do a pulse exam starting at the wrist, moving to the area just above the elbow to check the upper arm blood flow. We check the femoral pulse in the groin. That's at the top of the lower extremity, arterial perfusion tree. The next place I like to check is behind the knee at the popliteal artery. And then I also like to check two places around the foot and ankle, on the top of the foot and then behind the inside of the ankle, where I'm trying to feel for the pedal pulses or the foot pulses. If I can feel a good femoral pulse, that means generally there is not a significant interruption of blood flow from the heart to where I just felt the pulse, which is in the groin, if I'm checking the femoral pulse. If I move down your leg and I cannot feel the pulse behind your knee, that generally tells me there is a blockage or a narrowing from the groin to the knee. And that's very useful information when we talk about symptom management and potential intervention for those type of problems. And then the same rules apply when we check the lower extremity or the pedal pulses. The wealth of information that you can get just from a very good exam is tremendous. In addition to checking pulses, we look at the quality of the skin. Does the skin appear discolored? Is it well perfused? What's your pattern of hair growth? What's your pattern of hair loss? How do the nails on the toe, are they thickened? Are they discolored? All these factors come into play when we evaluate arterial blood flow in the lower extremity. When we move on to more objective measures, we think of things like an ankle brachial index, a duplex ultrasound, and a CT scan. The ankle brachial index is one of the simplest methods to uncover peripheral arterial disease. This is a very straightforward study used to initially assess blood flow. This study is completed with a blood pressure cuff and a Doppler. Basically, a ratio is calculated between the upper extremity occlusion pressure generated by a blood pressure cuff, and it's compared to that same occlusion pressure in the lower extremity at the pulse at the top of the foot and the one behind the ankle. If that ratio is 0.9 or greater, in most instances, you have normal blood flow to the legs. If that ABI is reduced, then that could be an indication of blockage, narrowing, or other issues related to the artery. The range at which that number returns gives us great clinical information about the degree of blood flow into the limb. Escalating the assessment, we can look at an ultrasound study called the duplex ultrasound. The nice thing about the duplex ultrasound is there's no radiation, there's no contrast. It's a very effective, very safe study to evaluate perfusion. We get multiple data points with an ultrasound. After the test, I can tell you what arteries are open, which arteries are closed, what is the flow dynamically through that artery at the time of the assessment. Is there normal flow? Is there evidence of stenosis based on an elevated velocity picked up on the ultrasound when they check the blood flow through that region? Is there calcification on the arteries that the ultrasound can identify? And then it also gives me waveform analysis to determine if the artery is a nice, healthy, reactive artery, or if that artery is injured to the point where there's significant calcification and it's lost its elastic recoil. So duplex ultrasound is a wonderful screening tool. It's a wonderful tool to use when we consider intervention or procedure, just given how much information we can glean from that study. The last non-invasive study that I like to use to assess patients with peripheral arterial disease, CT angiogram. So this study requires radiation. This study requires a contrast load. So generally, the patient has to have appropriate kidney function in order to be a candidate for this type of study, given the contrast given during the procedure. If there's a kidney issue problem, there are some things we can do, but at times this study can be prohibitive if the patient's renal function is very poor. A CT scan, though, does give very, very good anatomic data about the structures, the flow, what is occluded, what percent occlusion are we dealing with, what are the sizes of the arteries we're dealing with. I really like to use CT whenever possible if I'm considering an intervention on a patient, because I get such great anatomic information about distances, diameters, flow pattern, things to that effect. Generally, we use all of these in concert when we evaluate patients for peripheral arterial disease to gain the most insight onto your perfusion, your blood flow into your leg, so we can make improvements and improve your quality of life. So initial management for peripheral arterial disease of the lower extremities is medical therapy. And what that comes down to is a variety of factors where we talk about medical optimization. We make sure you're on the right medication. We make sure your comorbidities like diabetes, high blood pressure, high cholesterol, all of those factors are controlled. And then very importantly, we talk about a supervised walking program with our patients. And what that describes is generally a 12-week course that is offered here at Suburban and multiple other places in the region, where you walk with a therapist. And the goal of this program is to improve your walking capacity. Again, fundamentally, when I meet a patient in the office, they come in and they say, every time I walk, my leg hurts, it kills me, I have to stop walking. These symptoms can be, not too impactful, or they can go range all the way from they have a significant effect on my quality of life. Patients with lower extremity blockages generally respond very well to these type of programs, these walking programs. The goal is you walk, you stress the lower extremity to the point to uncover your symptoms. You walk a little bit further, and then you take a break. While working with the therapist, they monitor your heart rate, your blood pressure. They coach you, they guide you on strategies for improvement within the walking program. And then over that 3-month course, what I'm looking for is a nice to significant increase in your walking capacity to the point where we don't have to talk about an intervention. When it comes down to it, when we talk about intervention for this type of problem, we talk about symptoms that are still so severe They impact your quality of life. We refer to that as lifestyle limiting claudication. And so in an individual who is medically optimized, they're not smoking, they're on all the right medication, their comorbidities are well controlled. In that same group of patients, if they've completed the walking program and they are still not satisfied with their ambulatory capacity, and then they tell me at the end of the day, these symptoms impact my quality of life. They impact my ability to work. They impact my ability to enjoy the things that I want to do. I consider those patients very good candidates for intervention. So what options do we have? For the surgical management of peripheral arterial disease, we have the endovascular option, which is a minimally invasive technique where we use a tiny little incision in the groin to treat the arteries from the inside out with balloons, wires, catheters, stents. We have a multitude of techniques to accomplish those interventions. And then for some patients, we have the traditional open repair, where you make an incision and either repair the artery directly or construct a bypass potentially, which is a way to reroute blood around a significantly injured or blocked artery. So we have a case example here. This is a 51-year-old male patient who I saw recently. His medical history was significant for high blood pressure, and he was actively smoking. He came in reporting a 50-foot claudication distance, so a very, very short distance, and these symptoms were dramatically impacting his quality of life, his ability to work. On the CT scan, which is a reconstruction that you can see on the panel, kind of on the screen right here, there's a lot to look at, but I'll kind of point out the major blockage here. And so at the top of the screen, you have your aorta. That's the big artery that comes off the heart and provides blood flow to the rest of the body. You have your right kidney and your left kidney. The aorta splits to provide blood flow into the limb. Right around here is the groin or the hip joint. This is the common femoral artery. And then this little nubbin is the blocked artery in the thigh called the superficial femoral artery. If you can imagine, there should be an artery that connects this spot here straight down to this artery here. So this patient has occlusion of the entire thigh artery on both legs. You can see the same process here where you see just a little bit of a nubbin of artery. There's no artery here, nothing, and then reconstitutes. That artery comes back via these collaterals, and then pretty normal blood flow to the feet on both sides here. And so this patient presented with thigh artery complete blockage. And these symptoms, again, really impacted his quality of life, his ability to do the things that he wanted to do. So the plan we established, number one, which is the most paramount, he had to stop smoking. In my opinion, patients are not eligible for intervention unless they stop smoking. If I do a surgery on you to open the arteries with wires and stents and you continue to smoke, that repair will go down almost immediately within the first couple months. And so, because of that, for me, my practice pattern is you have to stop smoking. You have to prove to me that you're willing to stop smoking so we can focus on your legs and have a very good outcome with whatever we do surgically. So for this patient, he quit the day he walked out of my office. We made sure he was medically optimized, made sure he was on the right, medications like an aspirin, like a statin therapy, such as Lipitor or Crestor. He completed a walking program, still wasn't very happy. And then he returned for our interval evaluation to discuss his symptoms, ensure that he had given up smoking, and then really plan for the next steps. Given how he had done everything I had asked him to do, and we still weren't at a position where he was satisfied with his lower extremity performance, we elected to proceed with a minimally invasive intervention called an angiogram to augment the blood flow down to the muscles of his legs. So here's the first shot. This is the angiogram procedure. What you can see here is the catheter or sheath in the artery. We inject contrast so we can see what the insides of the artery look like. This is the common femoral artery in the groin. You can see, just like the CT scan indicated, there's a little bit of a nubbin here that I like to refer to as that you can engage and try to get that artery opened up. This is one of the thigh arteries, which is one of the principal arteries in the leg that provides that collateral blood flow down the limb so that these patients can tolerate a blockage of one of their principal arteries and not be in a situation where they're at risk for, losing their leg right then and there. And so when we take the picture, we have to define the blood flow above that area and the blood flow below that area. Again, very consistent with the CT scan. This is the knee joint down here. We see that artery comes back after this artery here provides all these little collateral arteries to reestablish blood flow in that territory. So, after two pictures, we have our lay of the land. We know where the blockage is. We know where it starts. We know where it ends. The next step of this endovascular procedure is to safely deliver a wire and a catheter across this blockage into this artery to reestablish, to reopen the inside of that artery. What this shot in the third panel shows here is precisely that. There's a catheter within this artery. We inject contrast, and this proves that I'm in the right space and the right artery in order to initiate the treatment. Here we see the wire is placed through that occluded artery and delivered past the zone of occlusion into the healthy artery. And then this is the results of the treatment after we balloon the artery. This gentleman responded very well to ballooning, and then I further completed a drug-coated balloon angioplasty. And that's just a fancy way for me to say on the outside of the balloon, when I inflate the balloon, it delivers medication to the inner surface of the artery. That medication reduces the risk of more disease formation, scarring, and inflammation in that area, and allows that balloon treatment to be more effective. So you can see if we go back from, no flow here to just a very nice uniform looking artery here, that's a tremendous improvement. And as we go further down the limb, we see there's still a couple areas that are irregular, but largely the flow was dramatically augmented. The patient did very, very well after this procedure. He basically denied any left leg problems when he came back into the office. He was happy with the results, and he's on the schedule for treatment of the right leg, I think, in the next couple of weeks. And the plan would be very similar, a minimally invasive endovascular technique to open those arteries. Ultimately, what we're trying to deliver is your function back. I want you out there exercising. I want you walking. I want you enjoying your life. And I want you not having to worry about leg pain when you do that. And, I like this healthy, active person, walking hard, looks like, palm trees and beautiful weather in the back. And I think that's probably a great place to go for a walk and exercise. So ultimately, that's what we're trying to achieve, improvement in quality of life, so you can do the things that you want to enjoy. Now, there's another side of peripheral arterial disease, which I generally refer to as advanced spectrum peripheral arterial disease. These patients present with gangrene, or which is another way to say just, dead tissue, or they present with chronic non-healing ulcers or foot wounds. This is a much different presentation to the group we just talked about, the claudication group or the exertional muscle pain group. These patients are at risk for limb loss, losing their leg and suffering an amputation. So in this category of advanced spectrum peripheral arterial disease, the thought process is very similar. However, in our evaluation is very similar. However, our treatment shifts to a much more aggressive surgical approach. So again, advanced spectrum peripheral arterial disease involves peripheral arterial disease, artery blockages, plaques, narrowing, all of that disease problem in the setting of non-healing wounds or necrotic tissue. Again, treatment options shift to a more aggressive surgical approach to reestablish blood flow to the foot to facilitate wound healing, or at times facilitate surgical wound healing if the patient requires a toe amputation. The goal of care in this situation is not to improve your leg performance and ability to walk without pain. The goal of surgery is to save your limb. It's limb salvage. where we do everything in our power to make sure you don't end up with a higher level, lower extremity amputation. The process, the evaluation is very similar. Our interactions, where I listen to you describe your symptoms, very similar. The radiographic assessment, where we talk about ABI, ultrasound, CT, all that's the same. At the end of the day, though, I get much more aggressive when my job is to save someone's leg as it is opposed to, mandating surgery for someone who comes in when they describe claudication. So that's I think I've got about 35 minutes on the clock right now. Might be a nice time to break. I have a lot more slides. Maybe I can get back on the schedule for a karate talk in the future. But maybe that'll be a great time to pause and get some questions and see what we have.
Thank you. Thank you, Dr. White. So, yes, so we have a few questions here. Let's see. The first one is, I have been told that I have mild reflex in my right knee. My ankle pulses are good and no pain on walking, just like pain while sleeping at night. Can reflux be caused by anything other than oh my goodness. Thank you. I'm like having a moment. So, or such as an injury. I completely ruptured my ACL in the knee 17 years ago, but did not need a surgical repair.
Yeah, so that's a very interesting question, and what draws my attention is the word reflux. And so when I see the word reflux medically, I think of a venous problem. The way we describe veins that are not working well in the leg is a process referred to as venous insufficiency or venous reflux. And when I use those terms, what I'm describing is the venous return. The veins are the structures in the body that basically, when the arteries deliver that oxygen-rich, nutrient-rich blood flow to the target, the veins bring that blood back to the heart. And so I guess my follow-up question would be, when we use the term mild reflux, are we talking about a vein problem? The next statement says, oh, you've got good pulses in your feet or ankles. And so again, if someone can feel a good pulse, usually that means there's uninterrupted blood flow from the heart to wherever they can feel that good pulse. And the fact that you're not having pain when you walk or exercise is a very encouraging sign that we're not dealing with a major artery problem in the leg. And so if the question goes back to, can venous insufficiency or venous reflux, cause pain in the limb? Absolutely. Oh, yes, I'm talking about a vein problem. I love it. So yeah, vein problems, completely different evaluation process for, completely different conversation, where we talk about, and that would probably be another great topic for the community, just venous insufficiency in general, where, folks with vein problems, they come in and generally they say, when I wake up in the morning, my legs feel great. As I'm vertical, at work or at home, meaning my feet are below the level of my heart, I get progressive heaviness, discomfort, fatigue. The legs just don't feel good. At night, in the evening, the legs can be very uncomfortable. And that's a classic description of that venous insufficiency or vein problems. And so, again, that's a whole separate talk. But, that can't, the symptoms described in the comment, potentially can be related to a vein problem.
So should they come see you or?
I'd be happy to see him. Absolutely. So I do arterial work. I do venous work. And so I'm always, happy to help, patients with either problem.
Great. I have a question. How, if someone has, a pain in their leg, how do they know it's artery, a cardiovascular issue, or if it could be oh my gosh, I'm blanking, or it could just be a muscle. Maybe they just have a muscle cramp.
Yeah, and so it's really when we get back to the classic presentation of peripheral arterial disease is really important. And it's these symptoms kind of in the box here, where, is it exertional based? Is it cramping in nature? Is your pain alleviated by rest? And the reproducibility of those symptoms is very important as well. So we go back to just what's our conversation when I meet you in the office? Like, how do you describe those symptoms to me? If it happens every once in a while, maybe it is more of a muscle strain, a musculoskeletal, process. But if you use these description of symptoms on this slide, then that gets my attention. And so sometimes we know, sometimes we don't know. That's why I'm a very low threshold to send someone for a study, either if I can feel pulses or if I can't feel pulses, in order to get objective data to support whatever I'm thinking. And so, in our evaluation process, it really is a process where we talk about symptoms, we do an exam, I send you for a test, and then we make, the best diagnosis we can and talk about options at that point.
Great, thank you. A few more questions. So when you do a procedure in the blood vessel, isn't there a risk that you will when you do a procedure in the blood vessel, is there a risk that you will loosen a clot that will travel to the brain or lungs?
So it depends on the territory you're working on. And so, any surgical procedure carries risk. And whenever I think of a endovascular procedure, I think of risk in three categories. Access, meaning when I put the needle into the artery in order to do the study and take that needle out. Contrast load, and then what I'm doing technically. And so the description of that clot breaking off is part of the latter, where what am I doing surgically? When I'm trying to cross an area of blockage or narrowing, there is the potential for that plaque or debris to break off, and we use the term embolization to describe that phenomenon. Now, in the legs, if plaque broke off, it would go further down the leg. It would not go to the brain. It would not go to the lungs. However, that can be a very serious issue or complication where I may have to emergently retrieve that debris, or you will suffer from an acute blockage of blood flow into the limb, and that can be a surgical emergency. At times, I can salvage that with wires and catheters. In the very rare instance, I would have to take someone to the operating room to make an incision on their leg to pull that clot or debris out. And so that is a complication or a risk that I talk with my patients every time I offer an angiogram. Now, when I think of things going to the lung, that's usually in the venous side of the house. If there's a clotting problem within the veins of the leg or the abdomen, that's generally when the lung is most at risk. When we talk about carotid surgery, which is a topic I'm not going to be able to cover today, that is a very real complication that we talk about in great detail about during the time of surgery. But every step of the surgery for carotid specifically is designed to mitigate that risk of having that plaque go to the brain and cause a stroke.
Oh, okay. Okay. So when someone is having leg pain to come see you, they should be making an appointment right away, or should they be going to the emergency room? Like the symptoms that you just described.
Yeah, so the symptoms of claudication, which I'm assuming are the symptoms I just described, they generally do not represent a medical emergency.
Okay.
Claudication represents a quality of life problem, related to activity. And so generally, I like the stance where, we get the primary care doctors involved. We involve them in the decision-making process. I always view the primary care doctor as kind of the quarterback of your medical care. And so, those symptoms are discussed with that type of provider. Then that provider escalates the evaluation process based on, their experience and their conversation with you to a specialist, which is someone like myself. And then we have the opportunity to work together to improve, like I said, your leg symptoms, your leg performance, your leg function, to the point that, you're moving around and you're happy, with the way the legs are doing. But generally, that's the way I kind of view medical care is, symptoms and clinical issues are initially discussed with your primary, then appropriately those concerns are elevated to a specialist whenever needed. And, I'm always here, my partner, Dr. Schulich, always here to help, always happy to be involved in the evaluation process. But I guess that's how I view the process going.
Great, thank you. We have a few more, some more questions, some more great questions. I was told that I had PAD as a result of an echocardiogram. What is the next step? Does that mean I definitely have it?
So that's an interesting statement because an echocardiogram is going to look at the heart exclusively. That's an echo. It's an ultrasound study that looks at the heart function, the heart performance. It looks at the wall motion within the heart. It's a very heart-centric study, obviously. It would be hard for someone to look at that and say, you have peripheral arterial disease. And so I'm not sure how to reconcile the study with the description. And so I would fall back on how do your legs perform when you walk or exercise? Are you able to walk any distance you like? Are you able to do the exercises that you want to do? Or do you have those list of symptoms that we've discussed a couple times? If you do, perfect opportunity to talk to your primary care doctor and say, hey, I have these symptoms. I'm concerned about claudication. I just heard a talk. I'd like to see a vascular surgeon. And then we can take it from there. But the echo is more of a study to look at the function of the heart as opposed to help quantify peripheral arterial disease in the extremity.
Great. This person says, I have an ulcer on the bottom of my big toe that has not healed in 2 years. I have type 2 diabetes. My podiatrist wants to amputate that part of the toe to prevent infection. My question is, should I consult a wound specialist for a second opinion?
I think that's a very reasonable approach. The other thing I would ask is, has your perfusion been assessed? Because blood flow is a critical component to the wound healing process. Type 2 diabetics are notoriously impacted by peripheral arterial disease. The process of diabetes impacts the microvasculature of the foot, but also on the larger scale, the arteries from the knee to the ankle. And so before any surgery is done, any definitive amputation, any aggressive wound care, I would kindly ask that you get a good blood flow assessment. That wound could be there for 2 years because you don't have enough blood flow to heal the wound. And we would talk about, a separate, intervention that question kind of falls onto the back half, the latter couple slides where, this individual has advanced spectrum peripheral arterial disease. They have a non-healing wound. And so it's imperative to define your blood flow before any major decisions are made, in my opinion. And so but I would encourage a wound care specialist. I think they are very valuable. Maybe even a second opinion from another podiatrist, before a big decision like a toe amputation is completed. There's nothing wrong with getting a lot of opinions before making those type of decisions. But fundamentally, the blood flow has to be perfectly defined before any major decisions made.
I agree. So next question is, at a health fair, my blood pressure was higher in my left leg than in my other extremities. How do I follow up with this? Is it reasonable to have different blood pressures in 2 different arms, 2 different legs?
Yeah, and so that's not terribly uncommon. To me, it comes down to symptoms. Because as a surgeon for this problem, I don't treat. I like this whole page. I don't treat numbers. I don't treat labs. I treat you, the individual. And so if your left leg is giving you problems, exertional issues, pain when you're walking, anything like that, now it becomes very reasonable to do an investigation. But and this is nothing against the wound, the provider who did the test or anything, but that data is hard for me to internalize. Your symptoms are a much easier thing for us to discuss. And so I would turn it back on, well, how's the leg performing? If we're having issues, let's investigate further. Let's do maybe a more definitive assessment, like an ultrasound, to really better quantify the blood flow in the limb, and kind of go from there.
If I have been diagnosed with neuropathy, not PAD, is there a surgical procedure to fix it?
Yeah, unfortunately, neuropathy is one of those very terrible chronic problems that there's really not a great answer for. There's nothing surgically to do for it. It's It's a peripheral nerve problem where those nerves just fail over time, and patients are left with numbness, tingling, sometimes nerve pain, and it can be very challenging to manage. At times, a neurologist can help us make a more established or more definitive diagnosis. At times, a pain specialist who specializes in nerve pain can be very beneficial. But there's no surgery that can improve the way the nerves are functioning. There's nothing from a vascular surgery standpoint that I could offer.
Okay, thank you. Is there any relation between temporal artery, oh my goodness,
Arteritis?
yeah, thank you,
Yeah,
and peripheral artery disease?
that's a great question. There is not. So temporal arteritis describes a inflammatory, autoimmune inflammatory condition that impacts the larger arteries in the body. This is an autoimmune or rheumatologic process where your immune system is attacking those larger arteries in the body. This is a completely different pathophysiology than atherosclerosis, which is the underlying problem for peripheral arterial disease. So both problems affect arteries, but completely different from a pathology, from a problem standpoint.
Great, thank you. And I know that you didn't talk about carotid artery disease, but since it is Stroke Awareness Month, May is Stroke Awareness Month, are there any things that you could just quickly touch base on for carotid artery disease? Like, should we all get our carotids checked? Is there anything that we can do maybe to prevent the stroke? Because, and I don't want to necessarily go into like a whole description, but if you have any, just, final words
Yeah,
about carotid artery disease.
yeah, carotid disease is kind of a tough one because a lot of the times we identify it, after an event has occurred, like a mini stroke or a stroke. Proactive screening, I as a vascular surgeon, I do feel is appropriate if you're someone who has, issues like peripheral arterial disease, like hypertension, high cholesterolemia, smoking history. It's very reasonable to discuss a screening carotid duplex ultrasound, which is really the best study to look for it, with your primary care doctor. It can be, it's challenging because a lot of the times patients don't know it's a problem until it's a problem. And so there's not a universal screening mechanism to facilitate identification. But if there's a family history of stroke, if you have a list of comorbidities, like I said, high blood pressure, high cholesterol, peripheral arterial disease, it's a very reasonable study to request from your primary care doctor.
Okay, thank you. Thank you so much. Were there any other questions that we had from our audience today, this afternoon? Well, Dr. White, if there aren't, I just want to thank you for your time. I think we're definitely going to have you come back, if you are available, perhaps even talk to our Thrive 365, our diabetes support group. Should they have lots of questions as well. But more on that to come, but we'll definitely come, invite you again another time. And thank you for your time. And if there aren't any other questions, I want to thank everyone for joining us this afternoon. And hopefully this was informative and insightful. So thank you and have a wonderful rest of your day.
All right, thank you.